Hello, everyone. Welcome to today's CPFF webinar, Creating Universal Blood Type Organs for Transplant. With our guest today is Dr. Marcelo Cypel. My name's Kelly Mills, and I'll be your host for today's session. We're incredibly honored to have Dr. Cypel with us today, talk about an exciting new development in lung transplantation. Earlier this year, UHN in Toronto announced that a team of Canadian scientists had proven it's possible to safely convert the blood type in donor organs. The findings are an important step towards creating a universal type O organs, which would significantly improve fairness in organ allocation and decrease mortality for patients on wait lists. Dr. Marcelo Cypel is one of the scientists involved in this research and will tell us more about it this afternoon. But first, let me tell you a little bit about him. It's quite an impressive resume. I just want to say he's the staff thoracic surgeon at UHN and an assistant professor of surgery at the University of Toronto. He received his MD in '99 and completed his general surgery and thoracic surgery residence program in 2004. In 2005, he started his postdoctoral research fellowship at the Latner Thoracic Surgery Laboratory, supervised by Dr. Keshavjee, and earned a master's degree at the Institute of Medical Science at the University of Toronto. During this time, he developed a new method of lung preservation and donor lung repair called Ex Vivo Lung Perfusion, or EVLP, which extends the life and of the lungs after they've been taken out of a donor. This method is now used clinically in Toronto and in many other centers and significantly increased the number of transplantable lungs. He subsequently performed a 3-year fellowship in thoracic oncology, cardiac surgery, and lung transplantation at the University of Toronto. During his training, he has received 13 awards, including the McMurrich Award, given for the best fundamental science work by any level trainee in the Department of Surgery, and the first annual Zane Cohen Clinical Fellowship Achievement Award. He also has been a large number of first author peer-reviewed publications, including high-impact journals such as Science and the New England Journal of Medicine. His main clinical interests are minimal invasive thoracic surgery for lung cancer, treatment of pulmonary metastases, artificial lung devices, and lung transplantation. Dr. Cypel's research interests include lung perfusion and transplantation, gene and cell therapy to repair injured organs, and lung cancer. In addition to EVLP, and an innovation led by Dr. Cypel is the use of light-based therapies to inactivate hepatitis C virus from donor organs. Dr. Cypel also had a major role in implementing a donation after cardiac death clinical protocol in Canada and standardized operating procedures in his lab, which enabled the group to test different strategies that minimize injury. Other current and future research lines include a study of lung protective compound that prevents vascular leak, to investigate novel oxygen carriers for lung preservation, to test a new bioengineered nanofilm on the surface of blood vessels, and to explore the effects of fusion toxin proteins that specifically target and inactivate viral infections during EVLP. And the work he's talking about today is to treat donor lungs during EVLP with enzymes that remove blood type A/B antigens, making lungs suitable for transplant to AB and O blood type recipients. So just one more note, Dr. Cypel is happy to take questions throughout his presentation. So please feel free to send me your questions during the Q&A using the Q&A function at the bottom of your screen, and I'll pose them to Dr. Cypel at an appropriate moment in his presentation. So, and now it's over to you, Dr. Cypel.
Okay, thank you. I think can you hear me okay?
Yes, I can.
Okay, good.
Seems to be okay. I'm not getting any comments.
Okay, so yeah, it's a pleasure to me to give this presentation to the Canadian Pulmonary Fibrosis Foundation. I interact a lot with pulmonary fibrosis patients here in the transplant program, and I would say that I probably personally perform one transplant every week in a pulmonary fibrosis patient here, and you know, it's a great pleasure to be able to help. I'm going to present about one of our latest projects. So I'm a transplant surgeon, but I'm also a scientist, and I enjoy the benefit of being able to, help with some discoveries, but more importantly, bring from the lab to the clinical arena to help patients. And so I think that's really, really good. So I'll start with a bit of an introduction, and as you are all familiar, blood type compatibility is a key requirement for organ transplants, as is for blood transfusion. So, if a recipient is an O recipient, they can only receive O type donors. If you are an A, you can receive O or A. If you are a B, you can receive O and B. And of course, if you are an AB, you could receive any type. Oh, sorry. The access to lung transplantation is not equitable because of this need to match blood type. And for instance, patients, for example, that have blood type O, they have a higher wait time on the wait list, and they have a higher, unfortunately, a higher chance of dying while waiting for a transplant comparing to other organs.
Dr. Cypel, sorry
yeah.
to interrupt. Can you give me sort of a brief, in the general population, what is the most common and what is the least common blood types?
Yeah, so O blood type is about 50%. And then you have about 35% of A, 35 to 40, and the remaining are B and AB. Now, it's also important that this depends a little bit of where you are in the world. These are statistics for Western world.
So other ethnicities, other groups will have a different.
Yes, for example, an Southeast, Asian will have a higher B proportion, for example, right?
Okay.
Than the Western population. So there are some differences there. Yeah.
Okay. Sorry to interrupt. Yeah.
Oh, no problems. Anytime. So so there are basically three things we need to look when we have a donor in terms of compatibility. The first one we look is blood type. So if I get, for example, a donor which is an A blood type, I ignore completely all my O recipients and I go only for my A list. Okay. And it doesn't matter if my O recipients are, some of them are much sicker than the A recipients, I still cannot look at them for that donor. Okay. The other thing we have to look then is the size. So of course, the size of the donor, it's also important. And the next thing is antibodies, like HLA antibodies is the other thing we look, but antibodies is not that critical. We have tools to be able to overcome that. But the blood type is the main one.
Okay.
So, to address the situation, we'd like to overcome the ABO as a criteria for matching donor to recipient. And I think this will make a more equal balance here. Now, if you do transplant a incompatible blood type, you develop a antibody-mediated rejection, okay? So what happens is everyone for example, if you are an O blood type, you have in your blood anti-A antibodies and anti-B antibodies, right?
Mhm.
So when you receive an organ which is an A blood type, for example, these anti-A antibodies in your blood will attack the organ and cause what we call this, antibody-mediated rejection. And this rejection happens right away. This is not the same rejection you hear about in a regular transplant, which we call cellular rejection, which is the one that you develop, let's say, a month after the transplant, you have a little bit worsening, and then you treat with steroids and you get better. The other type of rejection is that one that happens like many years later, that we call chronic rejection. This is also not, it's not the same what we're talking here. This happens in the first 24 hours after transplantation, and you have a very high chance of losing your graft because it can be a very severe rejection. Okay.
So I assume that doesn't happen. We don't transplant.
Well, I'm going to talk about that.
Okay.
But I'll explain a little bit more. In the past, there have been accidental transplants of the type.
Okay.
That's one situation. Things sometimes go okay, sometimes don't.
Yeah.
But I'm going to talk a little bit more. So as this figure shows here, in the blood of the recipient, there is these antibodies here that are floating, and they basically bind to the lung that you received, which is a different blood type, and they initiate this cascade of injury. Okay.
Right.
And it's mainly mediated by this called complement activation. And then this causes a lot of inflammation and blood clots and injury in the graft. Now, how can we overcome this? And in kidney transplant, there have been some successes of doing incompatible transplantation, okay? But it's for a very small subset. So what they do in kidney transplant is they use a very high immunosuppressive protocol that remove the antibodies from the patient that is going to receive the organ, and they increase the immunosuppression of the patient, okay? And that has been able to avoid this acute mediated rejection. This is just to show you here some of the results in kidney transplant. You can see here that they do have, so here is the incompatible compared to the compatible. They have a slightly lower survival, but it's still pretty good. But they do have a lot more deaths from infection. And the main reason they get that is because they have to use heavy immunosuppression, heavier than usual. Okay. So even before I go there, the other thing about the kidney transplants is that they only use a small subset of donors to a small subset of recipients. So when you look at everyone, let's say, that is in our wait list, which is an O blood type, the only ones that could be eligible for this protocol are the ones that we measure the antibodies in the blood, and they have very low antibodies of anti-A. And so, we measured, just to have an idea, in our wait list here, and we only have about 3 or 4 patients that could be eligible for this protocol. Right. So the majority of people have too high antibodies to be able to do this. Yeah. So if we could move away from treating the recipient, but actually treating the donor organ, maybe could be more efficient and less traumatic actually to the patients. And so this is the donor graft here in this figure. These are the cells in the graft. These are the cells that cover the blood vessels. They're called endothelial cells. And these are the cells that express these antigens, okay? So they are the blood sugars that, I'll talk more about that, but you know, the blood sugar that makes someone to be blood type A, this is in the edge of the cells, okay? And so if you could remove these antigens, then the donor graft maybe could accept the whole blood going through, even though there's a lot of antibodies in the blood, they won't recognize this as different because there is no more the antigens there. So there are 4 main blood type groups, as you know, the A, B, and O. And how are they different? They are different because they have this sugar at the, you know, at the red blood cells or in the cells that cover the organ. And this type of sugar is the one that tells you if you are an A, a B, or an AB. If you don't have that sugar, then you're a type O, which means that you don't have any, you know, of those different blood types. And the strategy that we use here are to use these enzymes that eliminate these sugars from the cell, okay? So it's very interesting how these enzymes were discovered. So who discovered these enzymes was a group from British Columbia, that University of British Columbia, that are our collaborators on this. And, they never thought about doing this for organ transplant. Their main interest was to use for blood transfusion. So they could, you know, transform blood to all blood type and to be able to be used for transfusion. And these enzymes they discovered, it's a bit, you know, you see how science kind of goes, but they screened the feces from people that are A blood type, okay? And there is bacteria in our gut. It's called Escherichia coli. You know, that's a bacteria everyone has in the gut. Okay? And this bacteria stays alive in the gut by eating this sugar from our cells in the gut. And so they screened the enzymes that these bacteria have in the gut, and they found 2 enzymes that were very efficient to take the A antigen out of the cell so the bacteria could eat that sugar, okay? And so they discovered those 2 enzymes, which are described here, and then they basically produce these enzymes at a more industrial level. So then we could use that as a treatment for this. And they first tested in the blood, and then in our collaboration, we started converting the organs, treating the organs.
Have those enzymes now, are they being used to convert blood for transfusion yet?
Not on the clinical arena yet. Yeah.
Okay.
Again, here is a bit, I guess, too technical from the paper, but skip a little bit because maybe I don't even understand that.
Okay.
The reason we can do this is because of this system called Ex Vivo Lung Perfusion. Okay?
Mhm.
And if you're probably aware, the way we used to preserve lungs is we go to the donor, we assess the lung is then retrieved from the donor body, and we put in a cooler of ice. Okay, it's the same cooler of ice that you use to carry on, your beer when you go to camping. Okay, it's a Canadian Tire cooler of ice.
Yeah.
Okay? It's nothing fancy. Okay.
No.
So and so we take the organ from there and we bring to the hospital, and we take the lung out of the box and we transplant to the patient. Now, the main problem with that method of preservation is, it doesn't allow us to treat the organ after the organ is removed from the body, right? Because the organ is no longer functioning
right
at that stage, okay? So what we developed here was, because a lot of the donor organs, they are not perfect, they have problems, can we actually make them better after it's removed from the donor? And that's the concept of the ex vivo lung perfusion, that we bring the organs back to life, to body temperature, we provide nutrients, we provide oxygen. And so what you can see here in this bubble is a human lung that is being basically treated during the ex vivo lung perfusion. And because the organ is functioned as it would be in the organ own ICU, you can give specific treatments. And this is one of the treatments that I am basically mentioned to you here. We have used this system already in over 600 patients here in Toronto, just that you have an idea. 600 lungs that wouldn't be used otherwise were already put in the system, revigorated, reassessed, and transplanted to patients.
So this is the 600. These are 600 that, do they all now go into this process, all lung?
No.
Okay, some just go straight.
About 40% go.
Okay.
Yeah. And 60% go straight to transplant. Yeah.
Okay.
Okay, I think here, just to answer your previous question, is what is the percentage in the Western world? It's always about 45, A is 40, and then B and so on. So what we wanted is to treat the lungs during ex vivo lung perfusion using this enzyme that was developed by the UBC team. And to start investigating this, we first tested in blood, red blood cells. Then we used just a piece of artery from the donor. Then we used the whole lung. Okay, so it was a stepwise approach. And so first we just tested in lung. And again, this is a little bit too technical. But just to show you here that this in red is the liquid that we use on EVLP. And you can see here that we achieved close to 100% removal of these antigens from the blood. Okay. Then the next—
From the blood or from the lung?
Initially from blood. That was the first experiment. Yeah.
Right.
Then the next experiment, we took a piece of the aorta. The aorta is a big vessel that we have. So when we went to the donor to retrieve the organs for transplant, we took a piece of the aorta because it's not used for, for other transplants. And then we brought this aorta to the lab and we immersed the aorta in this liquid here, which is the same liquid we use for ex vivo lung. And then we treated under different conditions. And then we looked at the cells, okay? And so here you see the brown stain here. The brown stain means that there is A sugars covering these vessels, okay? And when you treat the lungs with these enzymes, then you see here the brown is gone, okay? That means that these A sugars were removed from the endothelial cells, okay, of the aorta. This was still not the whole organ, okay? But you know, it's very difficult to get full organs for research.
Because they want them for the patients. Yeah,
exactly.
Sorry,
So,
yes.
so we wanted to first optimize all the protocol in smaller systems, right? And then we look at what is the right dose we need to use and the time of exposure and so on. And you can see here that, again, we were able to achieve very good removal. You know, we had left only about 2% of these antigens in the cells. As I mentioned before, you know, the A blood type, there is two subtypes. There is the A1 and the A2. Okay, so the A2, they have very low levels of A antigens, and the A1 is the majority of the population and have a very high expression. So what we're talking here is treating these A1 donors that have very high, which is the majority of the population, very high levels of A antigens. Here again is just to show the level of expression of these antigens in the organ, because we wanted to know, you know, are these sugars just in one type of cell of the lung, or they are in multiple areas of the lung, right? Because this was never studied before in organs. We always talk about, you know, the blood type as kind of a red blood cells issue. And we found out that is the in blue here is actually at the cells that covers the blood vessels are really the ones that have the very high levels of these sugars, okay? Because, for example, if this was in the cells of the airways, maybe putting this enzyme in the liquids that is perfusing the organ wouldn't be sufficient. We will need maybe to give some nebulization or inhalation to target the airway cells. But that was not the case, it was really in the blood vessels. Okay, then we moved on to whole organs. So you may ask me how we get lungs for research. Well, you know, unfortunately, 80% of the lungs that are offered to us, we don't use for transplant. And the reason for that is because these organs have too many injuries that is not safe to transplant them. Now, with the use of ex vivo, we moved from 20% to 40%. So we doubled the number of organs we can use. And that's the reason why we went from 100 transplants to 200 transplants here in Toronto, as an example, okay? But even then, even getting to 40%, there is still 60% we don't use. And hopefully one day we'll be able to use all of those. So then, you know, there won't be people waiting on the wait list, they will be listed and transplant. You know, that's really our dream. And I think we'll be able to get there, not too far away, okay? Now, so these donors that we can't use the lung, if the family has provided research consent, we send our team there to retrieve the organs for research. And so we take the lungs and we bring to the lab, and then we do the treatment as I described. These are just you know, some examples of, you know, who were these donors that we use the lungs. Here you can see the age of the donors. It's quite variable, male, female, you know, they were brain death donors or donation after cardiac death. And this is just the time of the treatment protocol. And so we did the treatment, and again here, what you'll see again is focus on this panel here. You see a lot of these brown stained cells. This was before the treatment. And here below is after the treatment. So you don't see the brown inside these cells anymore. Inside the blood vessels, this is a blood vessel, showing how efficient the treatment was. And again, here just showing only about 1 to 2% residual expression of these sugars. The other thing we can evaluate in this system is the function of the lung. So we could see that the function of the lung was stable, so there is no safety concerns by using these enzymes in the human organs, which always before bringing a therapy to clinics, we want to make sure it's safe before we know if it's effective. But this indicated that it looked to be safe from a lung function perspective. And then we also did some other inflammatory testing, and it showed that the treated and no treated, they were very similar. And then the final step was, does this enzyme really work? And the only way to know if it works is if you, after your treatment time, you can go and do the transplant to patients that have a different blood type. But we didn't have yet enough data to say it would be safe to do this. So the interim step is to get blood from people that have a different blood type. So we got blood from, Canadian Blood Bank had unused blood. We've had very high levels of antibodies against A blood type. And then we treated these A lungs with the enzyme or no treatment, just as a control. And then after the treatment, we put the blood in the circuit. Again, it's a bit too technical. I'm just going to move here to this slide, which is I can explain to you, is that, focus here in the blue and red. Okay, so the lung that we treated with the enzymes, the antibodies from the blood maintained stable levels, okay, because they have nowhere to go. Okay, now the ones we didn't treat with the enzymes, the antibody levels dropped precipitously. And that's because the lung was absorbing all those antibodies. They were attacking the lung tissue and there was no longer in circulation, okay? And, this is mainly caused by this, what we call the complement injury, but I just want to show you here, again, this complement deposition didn't happen. You can see here, pretty much no brown stain here. And more importantly, which is this is the most important message here, these are measurements of lung function. And we can see here that when air pressure goes up, means the lung there's a lot of injury in the lung. Okay, the lungs get water inside, they have edema, and then they become very stiff. Okay, and in the non-treated lungs, they became very injured very quickly, whereas in blue here, they maintain very stable lung function, which means that the antibodies in the blood could not attack that organ because they didn't recognize as a different blood type. So just as a summary, we show that the ex vivo enzymatic treatment can effectively remove blood type antigens from group A donor lungs without any acute side effects. That's this ex vivo reperfusion model showed that antigen removal prevented early antibody-mediated rejection. And what we are studying now is, can we go and do this in patients, okay? And to do that, there are a few challenges, and one of them is that there is no really good animal model because animals have different blood types than humans, okay? So it's a bit of a challenge. Otherwise, we would say, let's transplant, do a lung transplant in an animal model, and we can follow the animal for weeks and see what happens. We don't have this opportunity. So we have a few ideas of how to transition this to the clinical side in a stepwise fashion. Again, doing similarly what the kidney teams did, using initially just people that have very low levels of antibodies, use this donor treatment, and then expand on that over time as we see things become safer. And ultimately, the integration of this treatment into clinical practice will aid better organ allocation. And then, we can hopefully transplant the patients are most in need at that day that the donor offer comes, without having to look at the donor blood type. So I'll finish here. I'll be happy to have any questions and discussion.
Okay. Yeah, so that that really, I guess, is the ultimate goal. And any thoughts about the timing of that? What do you see? How long do you think it'll be before they're ready to do that kind of thing?
Yeah, so
or even to start the first steps, like to try it first with the low antigen people.
Yeah, so we're planning to start next year.
Okay.
So next year, the first few patients we'll do will be just to test, again, the safety of the enzyme further. So we're going to use, let's say, a donor and transplant a recipient, but we're going to use the enzymes to remove the A from the organ anyways, just to show that the enzymes are indeed very safe. That's step number one, okay? There is no indication to think that what they won't be, okay? Then the second step will be, we're going to use these A2 donors, which have low levels of antigens, treat the lung and transplant to all blood type recipients that have low levels of anti-A antibodies, which is basically what the kidney is doing these days.
Right.
But we will add this interim step of treating the donor organ, so we don't need to do further heavy immunosuppression to the patient.
Beforehand, you won't be doing that, right? Okay.
And then once we go in this fashion, then we'll expand further to the other A donors and A recipients. And this can also be done for B donors as well. There are enzymes to remove B blood type too.
Okay.
But yeah,
are they different? Are they different enzymes?
They're slightly different, yeah.
Okay.
But what we felt, if we can convert all the A's to O, then 90% of the donors will be O blood type.
Right.
And that will benefit all blood, A, B,
everybody,
right? So,
okay. 90% become O. Yeah. Okay. And I was curious, how long, because they still have the lungs still have a certain lifespan outside of the body before they're transplanted. how long does this process of adding treating it, the enzyme, using the treatment, how long
It's
does that
actually,
take?
yeah, it actually is very quick. So
Oh, good.
you only need like about 2 hours.
Oh, all right.
Yeah. In 2 hours, the sugars are completely removed from the cells.
And once it's reperfused or, alive again or functioning again, do the antigens come back?
That's a very important question, and the answer is yes.
Okay.
We don't know how long that will take yet, but we think it's going to be a matter of a couple of weeks. They will be back. Okay. And then you ask, well, isn't that going to be a problem?
Right.
And again, we don't think so, because based on the experience from kidney transplant, again,
Right.
they do that heavy treatment of removing the antibodies of the recipient during the surgery time.
Right.
And they don't do them after. And later on, there is binding of an antigen and antibody, but it doesn't cause organ injury.
Okay.
So
is that a component? Is that a component though of ultimate rejection or not?
No.
Okay.
It's a component. There
Something different.
There is a word in organ transplantation that is called accommodation. So relative to the blood type, the rejection, which is relative to the blood type, it either happens in the first 24 hours,
right,
or it doesn't happen after.
Okay.
Yeah,
okay.
That's the general understanding.
So
but
wait and see.
Still need to see. Yeah.
Right. Okay. So like in the kidney thing, or like you said, that's if it's a blood type mismatch, that rejection or happens almost instantly, right? Like you said, within 24 hours. So if you can hold that off for a certain amount of time, then the hope is that it won't be an issue. But we won't know, or it hasn't been an issue for the kidneys, so maybe not for the lungs too. That's your hope.
And also, as I mentioned, in the in the accidental transplants in lung as well, that happened before. That has been also the experience, is that people either became very sick very early, or once they went through that phase, they were okay.
Okay. Would people need to, I'm guessing no, but the anti-rejection drugs that people take post transplant, would those be reduced at all, or they'd be the same?
No. So that's a very good question. This approach is not going to, if we can do this approach and not have to change anything on the immunosuppression, it's a major win.
Okay.
Because that already means that we're creating more organs available for everyone.
Okay.
But our main goal is to be able to modify the organs ex vivo so that people can use less immunosuppression. But then it's a topic of subject of many other research we're doing.
Not just this blood type change,
not the blood
right?
type. Then you need to, other strategies to decrease immunogenicity of the organ, right? So we have like gene therapy approaches, we have stem cell therapy approaches, we have what we call immunocloaking approaches that.
So it's keeping that rejection from kicking in, so to speak, right? It's making the lung as much like
self as possible,
as like the person receiving it, right? Okay.
Yeah, that's our ultimate goal.
Of course. Well, yeah. Or would we prefer actually to have an artificial or a grown, I mean, we're looking far out, but something that's
right,
isn't going to have a rejection component at all, like you're creating it from scratch, as opposed to needing donors, It'd be great if you didn't need donors, really, wouldn't it?
Yes, yes.
Yeah.
I mean, we do have artificial lungs, right?
Mhm.
And but they are very, we use a lot of those artificial lungs. Actually, in COVID we use those all the time, but they are temporary support, right?
Right.
So they last for from a few weeks to a few months,
Yeah.
and they replace the function of the lung completely. And
This is like
sometimes,
when they talk about someone in ICU going on a respirator. That's kind of what that's
oh
part
no,
of what
the
it is, or it's a
respirator,
little more.
it's different because the respirator is
Oh,
still
you have
used
to
for
oxygenate the blood. Sorry, right?
yeah,
So it's kind of like respirator, dialysis, you name
yeah,
it, everything all in one. Yeah.
yeah. It's a machine that takes your blood out,
Right.
and then there is a membrane that exchange the oxygen and put the blood back to you, similar to what a dialysis do for kidney.
Right.
But there's a lot of research also in this technology to
Mhm.
make it more durable and portable. So maybe one day we could also have just off the shelf devices that we can connect to patients
Yeah. But
and
still, it won't be the same. You'd always have that thing, unless it's something that you implanted,
yeah.
right? It would still be a thing. Who would be eligible? So when we're talking about this, you talked about the stages. So I guess the beginning of patients receiving them would be
Mhm.
an
Yeah.
old
So
person, probably with
yeah.
low A antigens. Like, and
So
how would they be chosen? Like, is that something you'd be looking at the wait lists for that kind of, and to obviously talking with the patient and family, whether they're
yes,
interested in going this way? Yes.
yeah.
How
So
would you
yeah,
choose?
for the initial step, we'll have to screen all our O blood type
Right.
patients and measure the anti-A antibodies. Okay.
Right.
So the ones that have a low level, those are the ones that will be eligible for this first phase.
Right.
And then, of course, we'll approach them and say, you want to participate, and
So they wouldn't get a hold of you. These are people who are already on the waiting list, I would assume, for
yes,
lungs. Yes. Yeah. So they don't have to, send their thing to somebody. Oh, okay, I'd be interested. Do you think that there'll be an issue getting people to, I mean, it's quite how much more risky would that be, I guess, than
yeah. I mean,
in the early days anyway?
yeah, in
It
the
would
early
be.
day, I mean, I learned that lung transplant patients are very altruistic,
Mhm.
and they really don't only think on themselves all the time, but they also feel how can they contribute to help others.
Mhm.
I went through this phase even when we're starting the ex vivo lung perfusion. I would get to the patient and say, look, there are two types of donors: the ones that we know the lungs are good and we transplant directly, and the ones we don't know if the lung is good and we have to evaluate in this machine, and then if it's good, we go ahead and transplant.
Mhm.
And it was remarkable how basically everyone wanted to participate, right? And I think this will be similar, and because we're doing in a stepwise fashion, and there is some data in kidney to back up,
Mhm.
that even if these enzymes don't work, there's still ways to overcome rejection down the
That
road.
early phase of
Yeah.
rejection. Okay. Steps too. I don't know if anybody sent anything else. I'm just gonna have a little peek here. Just 1 minute. I think that's everything. So
Yeah, I
I
think
guess I
you
could.
made very good questions. You covered
Oh,
really
it
well.
wasn't. They weren't just for me. I was jotting them down like as they were coming in. So yeah. because it wasn't just for me. But thank you very much. It was, I found it very informative. I'm sure our audience did. And for everybody, please go ahead to make sure that you fill out the poll when you're exiting the session. It just helps us to improve our offerings for webinars. Thank you so much, Dr. Marcelo and Cypel, and thank you for all the work that you do in your clinics and your labs, and for making hopefully, you know, a lot more lives a lot better, especially you know, the people in our audience with pulmonary fibrosis. And we hope that you have every success so that everybody's life will be a little bit better. Thank you again. Thank you, everybody.
Thank you.
And
Thanks for the
this
invitation.
will be available online next week. So if you know someone or that missed it today, or you want to see it again, feel free to do that. Okay, thank you.